platelet function studies to guide antiplatelet therapy. Platelet therapy is a cornerstone of coronary artery disease, and the role of genetic and platelet function tests are a hot issue. To know more about this issue, we have two excellent speakers to illustrate pro and contra position, despite having written a paper together. First of all, we would like to thank the excellent collaboration of both speakers for preparing the controversy. The controversy has been structured in two parts. The first one is the argument exposition in pro, 18 minutes, followed by argument exposition in contra, another 18 minutes. In the second part, each speaker has 4 minutes to refute the opinion of the opposite speaker. Finally, we'll have about 10 minutes for general discussion. The first speaker is Dr. Dominick Angiolillo, Director of Cardiovascular Research and Associated Professor of Medicine at the University of Florida College of Medicine in Jacksonville. He has a great experience in this field, and we can see from the wide number of publications in so many important journals. He takes the position pro. Dominick, it's a great pleasure to have you here and to listen to you again.
Thank you, and good morning, everybody. And it's a pleasure to be here to have this debate with a good friend. This is the big Italian debate, Northern Italy versus Southern Italy. Marco's from Milan, I'm from Sicily. So I'm going to, over the next 20 minutes, I'm going to try to convince you that genetic testing and platelet function testing should be used in your clinical practice. And we all typically start off with a conflict of interest slide. And this is my conflict of interest slide. And I cannot hide, because I've actually been a proponent in the scientific literature. This is an editorial that I wrote in JAMA a few months ago, where I'm the first one to say that these tests should be reserved mostly as a research tool. So here I'm in a position to have a pro. So not only I need to convince the audience, my opponent, but I have to convince myself that these tests should be done routinely in clinical practice. So let's see how I do. So our starting point, you've probably seen this slide many times, is that if we were to do a platelet function testing in everybody in this room, we see a broad variability in response, and we know that patients with high platelet reactivity have a higher risk of ischemic events, low platelet reactivity, higher risk of bleeding. And the question that we have is the following: is platelet function just a marker or a modifiable risk factor? And the only way to answer this question is by performing strategies of testing and see if modifying therapy can have an impact on clinical outcomes. So where's the evidence? So I'll start off with the indirect evidence. And the indirect evidence comes, in my opinion, from the Triton and the Plato trials. Why? These were strategies to support that higher levels of platelet inhibition with stronger agents in high-risk settings, ACS, are associated with better clinical outcomes? And the answer is yes. We also know that this is also associated with increased risk of bleeding. So here we have some take-home messages. First is a proof of concept. Yes, with higher platelet inhibition, in high-risk settings such as ACS, known to have high platelet reactivity, we can improve clinical outcomes. So yes, we do have evidence, indirect evidence. However, we know there's variability in response between subgroups. We know that patients on prasugrel and ticagrelor bleed. And we know that many patients on clopidogrel just do perfectly fine. So why not do platelet function and genetic testing to tailor treatment? Makes sense. Save money. You can avoid using more expensive drugs, and you can prevent a lot of bleeding complications. Now, this is a cartoon that I like to present all the time, but for this presentation, I gave them Spanish names, Javier and Paco. So both of them met in the CCU. They both had a heart attack. They're ready to go home. And we see that in Javier, he's a big boy. We need to tailor his doses of antihypertensive medications, cholesterol medications, to reach certain targets. Okay? But we're sending him home on the same dose of aspirin and clopidogrel. And the whole reason why they went to the CCU with a heart attack is because their platelets were sticking together too much. So it doesn't make too much sense. We need to tailor treatment. And here you see the different targets, for example, in clopidogrel response. We're going to be speaking a lot about this. This is introducing the concept of pharmacogenetics. And you can see that we're going to speak a lot throughout this presentation of one specific marker, which is a CYP2C19. So the arguments that I'm going to have to say today to support doing testing are the following. First, it's easy to do. Second, risk stratification. Third, clinical guidance. Fourth, improved outcomes. And ultimately, better patient care and cost saving. Let's start. Easy to do. There are many ways of doing platelet function testing. We have point of cares, such as the Verify Now. I always say even an interventional cardiologist can do it. We've transformed ourselves to be scientists or consider ourselves scientists because we have point of cares. The same thing is for genetics. Okay, this is one machine. It's a buccal swab. In 60 minutes, you have the result of your genes. Very easy to do. Second point, risk stratification. Okay, here you see the bell-shaped distribution of platelet function. This is a recent analysis in JACC intervention, also from an Italian group. And you can see we can define a therapeutic window. Okay, we can define levels of platelet reactivity where we want to be to avoid bleeding complications and to avoid ischemic events. And we've seen something very similar with genetics. This is a meta-analysis from Jessica Mega, and you can clearly see that there's a gene dose effect. So more of the bad genes, higher the risk of a thrombotic event, including stent thrombosis. And as we go into details and we look at 2C19 genotype, you see that we can look at other alleles, such as the star 17, which is associated with increased function. And if we apply this into our clinical practice, we can identify patients at a higher risk of bleeding. So a lot of useful information. And now if we combine the information, genetics and platelet function, we can come up with a scoring system. This is coming from another group in Italy. Italians have been pretty prolific in the field. You can see that we can identify patients with a higher risk of having a recurrent ischemic event, and we can apply this in our clinical practice. Now, I'm quite sure that Marco is going to tackle me and say, well, you guys just published a study in JACC and you had to stop the trial because there weren't any clinical events. I had the opportunity of being the co-PI in this trial with Greg Stone, and we had to stop the trial because there weren't any events in this cohort of patients treated with prasugrel. So the problem here was we learned that we need to integrate platelet function and genetic testing in higher risk cohorts. Clinical guidance. This is a report that we published earlier this year in JAMA from the Bridge trial using cangrelor in patients undergoing bypass surgery. I'm not going to go too much into the details of the trial itself, but you can see that this trial was very, very useful in guiding patients to surgery and looking at their levels of platelet inhibition so that they would be protected by the time they went to surgery and to prevent recurrent ischemic events. And at the same time, we can see that when you stop the infusion, patients' levels of platelet reactivity go back to baseline, and we can send patients to surgery. This was very useful because point-of-care testing allowed us to do this study in 5 different countries worldwide. This is another study looking at patients undergoing surgery coming from Paul Goebbels' group, looking at another device, which is the TEG. And the uniqueness of this study that it allowed to give different time frames of sending the patient to surgery. So why wait 5 to 7 days for all our patients just treated with clopidogrel? There's no need. You test their platelet reactivity, and you can see here from the side, you can reduce waiting times by 50%. That's cost saving. Improved outcomes. So these are the different strategies that we have today to improve outcomes. Let's start off with the first, which is using higher doses of clopidogrel. We have the landmark study from Lauren Bonello showing that if you tailor treatment according to your levels of VASP, you could send patients to PCI, and you can see that there are virtually no events in patients with tailored treatment. Another major trial, the Gravitas trial, and this was the largest trial using a point-of-care device, considering a cutoff of 230 and randomizing patients to tailored treatment versus standard therapy. And you can see here that the trial results were a little bit disappointing. There were no differences. So we did this large clinical trial and no differences. And so the question is, what went wrong in this trial? Well, the first thing to look at is look at the event rates, 2.3%. I think this is a success for the interventional community. It means that we're doing a pretty good job. So we need to focus our attention on something else. And I always like to put here what went wrong. Was it the patient population? Definitely yes. The strategy used, 150 milligram of clopidogrel. My opinion, yes. Timing of sampling and cutoff values. The answer is yes to all of these, and let me just show you why. What we saw in the trial was that if you were treated with 150 milligrams of clopidogrel, you have very little effects on response, and we knew that from previous trials. But if you see here, even with the standard dose, patients over time improved response. So maybe the timing of sampling was just not the best one, and definitely the cutoff point was not, because we did this post-hoc analysis, and then we found that 208 was actually the best cutoff point and not 240. With regards to the dose of clopidogrel, 150 was just simply not the way to go. This is another study that we published in JAMA just a few months ago, which is the ELEVATE study. And you can see here that even going up to 300 milligrams daily maintenance dose, if you're a poor responder or poor metabolizer, you're really not going to get too much bang for your buck. And if you're a heterozygote, you need to use 225 milligrams. Other strategies, 2B3 inhibitors. Very nice study, which is the 3T2R, looking at using 2B3 inhibitors in patients where we never use them, the elective patients. So patients were stratified according to their response, and you can see that if you use tirofiban, you can reduce periprocedural myocardial infarction. And this is another study coming from a group in France doing the same thing with using AB6 showing the same identical results. And so consistency in results, that's also very important. And using alternative drugs. This is a nice analysis coming from our colleagues in Canada, showing that, for example, with prasugrel and doing genetic testing in the cat lab, you're able to abolish response. Now, based on these preliminary data published in Lancet just a few weeks ago, there's another very large trial in all comers coming in for primary PCI doing genetic testing with the assay that I just explained. And you can see here with ticagrelor, we have the same identical results. I'm not going to go into many of the details, but you really get a complete response. Now, if we look at the outcomes with prasugrel and ticagrelor, this all makes sense, because if you know you're a poor metabolizer, or if you're not, or you're very high risk, it really doesn't matter. But if you look at this next slide, it's not the correct way of interpreting clinical trials, but I'm going to draw a line here. You see with prasugrel, no differences according to your carrier status. But if you look at clopidogrel, you look at the non-carriers on clopidogrel, and you draw a line, 8% event rates, very similar, even lower to those patients treated with prasugrel. So one can make the argument that why treat patients with more expensive drugs if they're going to do perfectly fine with clopidogrel. So if you take all the bullet points, easy to do, risk stratification, clinical guidance, and improve outcomes, it is natural that you're giving better patient care, and this is cost saving. So, dear Marco, does one size fit all? The answer is no. There's need for individualized treatment. Thank you very much for your attention.
Thank you very much, Dominick, for your splendid defense of the proposition. Now it's a great honor for me to invite Professor Marco Cattaneo from Clínica Médica Ospedale San Paolo Milano University to expose the Contra position. Professor Marco Cattaneo is a recognized authority in this area. He is member of the Thrombosis Working Group in European Society of Cardiology. He has a long experience in this field about coagulation, both growth and control. He has participated in international trials and his publication include the complete spectrum of thrombosis. Let me say that from the last night dinner is also a very good friend. So, Marco Cattaneo, just welcome and go ahead.
Thank you very much, especially for the last words. And thank you for the invitation. So Dominick has done a beautiful job as usual. I have to try and oppose him. First of all, I would like to mention also aspirin. You know that the controversy about variability in response to antiplatelet agents started with aspirin. Now I'm happy that nobody speaks about aspirin anymore, because it is quite clear that the vast majority of patients respond well to aspirin. There is no so-called aspirin resistance. This is the right study to be done using serum thromboxane B2 to measure the response to aspirin. And you see that among about 700 patients, only 2% had a poor response and was due in most instances to no compliance and underdosing. So let's forget about aspirin in terms of monitoring or other things. And focus on clopidogrel, as Dominick did. This is a meta-analysis by Brouwer and co-workers who took into consideration 6 studies which Verify Now was used as a platelet function test, and you see the consistency of results. There were patients who responded very badly to clopidogrel, patients who respond very well to clopidogrel, and if you draw a line at 230 as a supposed cutoff value, you end up with about 35% of patients who do not respond correctly to the drug. And no surprise to me is that those patients who did not respond correctly to the drug had a much higher incidence of major cardiovascular events compared to patients who respond well to the drug. What are the main causes of poor responsiveness to clopidogrel? There are many variables, as you know. One is the polymorphisms of a cytochrome that Dominick has already quoted. You know that this STAR2 polymorphism of this isoform C19 of the cytochrome is associated with a very poor capacity of the patient to metabolize clopidogrel to the active metabolite, and as a consequence to have a good inhibition of platelet function. And as Dominick mentioned, there are meta-analysis, is the one by Megan and co-workers, which did show that patients carrying the loss of function mutation of cytochrome and are treated with clopidogrel are not protected from major cardiovascular events as well as patients with the wild-type cytochrome. However, 3 more recent meta-analyses did not confirm this association, as you may know. The first one was by Brouwer. You see there is no association here. There's a trend, but no association. There is an association with stent thrombosis, which is a very rare, albeit severe complication, but not with the other major cardiovascular events. There is another meta-analysis which I skipped because of time, and the last one by Holmes and co-workers, which has been criticized, but it says basically the same as the meta-analysis that I skipped. The association could be seen only in very small initial trials, where in the big ones, this association is lost. And this is not the first time that something like this happens when you consider an association between genotypes and clinical events. And the other variable is PPIs. You know that patients who are treated with omeprazole and clopidogrel do not respond to clopidogrel, as well as patients who are not on treatment with omeprazole and other PPIs. And this is consistent across many studies. However, the only study which tested the effect of a co-administration of PPI of omeprazole and clopidogrel in a randomized trial failed to show that there is any association between the co-administration of PPI and clopidogrel and vascular events, which is against the association between what you find in the lab, platelet function testing, and what you find in the clinical setting. So, as Dominick has mentioned, the proposed solution is to tailor treatment based on platelet function tests. First of all, I would like to tell you, well, there are 2 questions, in my opinion, that should be answered. Is it a desirable solution to the problem of the wide inter-individual response variability to clopidogrel? Well, tailored treatment has been proposed as the future, as the individualized treatment and so on. It is actually an old remedy of yet unproven efficacy in the case of antiplatelet therapy to the problem of response variability to antibody drugs with unpredictable bioavailability. We have been doing it for decades for vitamin K inhibitors, antagonists, and for unfractionated heparin. This is not the future, this is the past. And there are many cons as far as monitoring is concerned. The cost is increased, of course. The workload is increased. The inaccuracy, please do not forget that there is no one single test in the world which has a sensitivity of 100% and a specificity of 100%. We are happy if it is 90 and 90, so we can miss 10% or 20% of our patients. So this is very important. Patient discomfort, and Baroletti, another Italian, showed, in America, showed that patient adherence also is decreased if you monitor them, may be decreased. So when possible, the use of alternative drugs with more uniform and predictable bioavailability and favorable risk-benefit and cost-benefit ratio should be preferred to monitoring. This is the reason why, as far as anticoagulant treatment is concerned, we are trying to get rid of laboratory monitoring and use drugs that do not need it. The best example is low molecular weight heparins, which replace unfractionated heparin, and we can use them without monitoring. For a strange reason, as far as antiplatelet therapy is concerned, we are going the other way around. We never monitored, now we want to monitor. It's kind of schizophrenic situation. So, but let's suppose that this is the best solution. The question is, are we ready today to use it in the clinical practice? So we have to identify the most sensitive and accurate laboratory test. Oh, sorry. And this is just an example. If you compare Verify Now with Multiplate, which is also considered a very good test, which can predict major cardiovascular events, you get this. Very good correlation, of course, but in terms of accuracy, it's very poor. These patients are considered poor responder with the Multiplate and good responder with the Verify Now, and these ones, the other way around. So depending on the test that you're choosing, the treatment of your patient changes. Is it correct? I don't think so. And then standardized pre-analytic and analytical variables. Dominick mentioned something like this. Time since start of therapy, times since the last dose, time of the day, platelets have a circadian rhythm, how many times during treatment, and many others, which we don't know the answer. And identification of universal cutoff values, this is a question mark again. We'll come back to this later. And clinical validation. Dominick already mentioned to you the negative gravitas trial, so I don't waste time. He also told you that one of the possibilities for explaining the negative results is the wrong choice of the cutoff value, 230 PRU. And you know that, and Dominick told you that if they used another cutoff value of 208, which was suggested by Campo and co-workers in 2010, they would be able to predict vascular events. And so the trial would have been possibly positive. However, I'm puzzled here because Campo and co-workers 1 year later said that it's not 208 anymore, it's 235. And you know that the meta-analysis that I mentioned before stresses that it's 230. So I hope that you are as confused as I am, and everybody is. We do not know what is the cutoff value. And if you want to look at what happens if you apply the tailored treatment based on platelet function test in your clinical practice, and see what happens. Just look at this study. This is an observational study. It's not a randomized clinical trial. It's an observational study on about 800 patients who have been treated based on platelet function testing in Florence, in my country. It's just clinical, 2 days clinical practice. So they were tested with the light emission aggregometry, EDP-induced, and they were treated with higher doses of clopidogrel, up to 300 milligrams daily, or ticlopidine up to 1 gram per day, until the platelet function test was depressed enough, okay? And those who had a high on platelet reactivity were at higher risk of major cardiovascular events, so the cutoff value was okay in this case, at variant with gravitas. But what happens when you therapy adjusts these patients. Some of them remain high platelet activity, some of them are well treated, but what is the outcome? Absolutely the same. Nothing changed for these patients. So this is the situation now. So this is another option by genotyping, as Dominick already told you. The problem is this genotype accounts for, it has a sensitivity of 45%. According to these data, it accounts for only 5% of the variability in response to clopidogrel. And according to this more optimistic data is 12%. That's very low, I think. And Dominick told you that how difficult it is to improve the situation in homozygous carriers, but also for the heterozygous, you need a very high dose of clopidogrel. You're talking about cost, but if you triple or multiply by 4 the dose of clopidogrel, also the cost will triple and be multiplied by 4. And Dominick already told you that there are promising results using prasugrel in this very small study. So I will skip this. So, but is there any other solution? Yes, change the drug. Use a good drug, which gives a very good inhibition of platelet function in all patients, or in the vast majority of patients without monitoring. There are two concerns. One is safety. Both prasugrel and ticagrelor increase the risk of bleeding. Okay, but this is what we expect from drugs which inhibit platelet function correctly in all the patients. What happens if we compare patients who are treated on clopidogrel, compare those who respond well to those who do not respond well? We see that the incidence of major bleeding events is higher in those who respond well. That's for sure, because the greater the inhibition of platelet function, the greater is the risk of bleeding. And sure enough, we want all our clopidogrel-treated patients to become responders, which means that we want them to be exposed to a higher risk of bleeding, exactly like treating them with prasugrel or ticagrelor. So there is no concern about bleeding, in my opinion. The only concern is about cost, as Dominick already told you. But are we sure that tailored treatment is less expensive than just using plain new drugs? This is the cost of monitoring. A cartridge of Verify now is 75 euros. And we know that we don't need only one testing. We need several testing. And then we have to multiply by 2 or 3 the dose of clopidogrel, or better, use the new drugs in the 30% of patients who do not respond to clopidogrel to start with. So are we sure that it is cost-effective monitoring? So this is the study that we need, but it will never be done. We have to compare platelet function test guided treatment versus non-platelet function test guided treatment with the new drugs, and see what is the efficacy, safety, and cost efficacy. And my last drug is a very old one. I used it for the first time in 2004, and says exactly the same as Dominick wrote in his first slide, that platelet function testing should be used only in the research setting, not in the clinical setting yet. Thank you for your attention.
Thank you, Marcos. Dominick, you again.
So as I had anticipated from my talk, I knew I was going to agree 99.9% with everything that Marco said. And, but I'm going to have 5 more minutes of glory to give a rebuttal. And I'm going to start off with the guidelines. And actually the guidelines really don't give me too much support, because you can see there's a class 2B, level evidence B, and level evidence C for platelet function and genetic testing, and a class 3 against routine testing. So what does this all mean? And actually the PCI guidelines also for platelet function is 2B, level evidence C, expert consensus. But there's some hope. And if the chair ladies allow me, I'd like to be an expert for the next 5 minutes. And we'll start off with a case. Here we have an African-American male of 76 years of age who comes to the ER with chest pain and dyspnea. His EKG shows SET wave changes and small Q waves in the inferior leads. The physical exam, heart rate of 88, some occasional PVCs, and a blood pressure of 130/90. And you can see here he has some heart failure symptoms. The patient has known CAD. He had an MI 6 years ago who was treated medically at an outside hospital. He has type 2 diabetes, multiple cardiovascular risk factors, hypertension, dyslipidemia. He was a smoker. He has PAD, chronic kidney disease. And 5 months ago, he had a GI bleed. He was on aspirin 325. Don't ask me why he was on 325. It was the dose he was on. And it was reduced to 81 milligrams. And his current medications are aspirin, insulin, lisinopril, pravastatin, and pantoprazole. So the patient, you see his labs here. Nothing really that remarkable except for his creatinine clearance of 55, high glucose. His cardiac enzymes are negative, but BNP are high. So clearly, it's a patient with congestive heart failure. His EF is 15 to 20%. It was 45% a year ago. The patient comes in, he refuses a viability study and wants to go straight to the cath lab. We fully agree. So here you see his angiogram, a very complex anatomy. His occluded right, he had an MI, inferior MI 6 years ago, and a distal left main disease embracing the ostium of the LAD and the ostium of the circ, extending into the prox circ and the prox to mid LAD. And the patient is very clear. He refuses CABG. He does not want to go to surgery. Overall, a doable procedure. Not going to go into the technical details. Using a support device, an Impella, a barrel stent in the LAD and into the circ, getting a good angiographic result, and the patient sent home on a dual antiplatelet therapy, aspirin and clopidogrel. Now, keep in mind the patient had a GI bleed a few months before. He's 76. We said, let's go the conventional way, aspirin and clopidogrel. So the patient improves remarkably, and at 2 months, his EF is actually now 35%, but at 3 months, he's starting to have chest pain again, the same exact symptoms. Patient comes to the hospital, he refuses a viability study, and he goes to the cath lab. And here you see severe in-stent restenosis in the distal, inside the stents. And the question here is there a role for platelet function testing in this patient? Well, CABG is discussed, and the patient is informed on the bleeding risk because he's on dual antiplatelet therapy. And the patient is very impatient. He doesn't want to wait. So we do a platelet function test. The verified now comes back as 208. So it's a very good responder. So what are the take-home messages here? First of all, we know that the patient's at increased risk of bleeding. Okay? So there's a clear clinical utility of platelet function testing in this given patient. Second point, this provides some guidance on what's the best time to go to surgery. So potentially cost effective. We showed that also with one of the other trials. And it helps the patients make their own decisions. In this specific case, the patient refuses CABG. Patient satisfaction. We want our patients to be happy. In the United States, we get judged on how patients are happy or not with their care. So you see a lot of positive things. So again, I'm not going to go into the technical details. We had to do IVs to make sure that the wires would not cross across the stents and go in the correct arteries. Put 2 small drug-eluting stents, getting a good angiographic result. So at this point, the question is there a further role for platelet function testing? And I'll show the answer is yes. Well, first of all, the patient is happy that he did not have to undergo CABG. That's a good thing. The patient is informed on the potentially fatal consequences of stopping his dual antiplatelet therapy because that's a patient with multiple drug-eluting stents in the left main LAD and circ. So we have a very informed patient who's concerned about his dual antiplatelet therapy. He wants to make sure that his drug is working because he says, well, he went to University of Florida in Jacksonville. They tested his platelets. Okay, so he read on the internet. And so we test his platelets again, and he has a PRU of 215. So as Mark already said, which is the correct cutoff? Is it 230? Is it 208? Let's call him a borderline responder. Now, do you feel comfortable sending this patient home with 4 drug-eluting stents in the left main LAD left circ with a PRU of 215? I wouldn't. So we switch him to prasugrel. He's 76, but according to the FDA, in a diabetic above the age of 75, we can use prasugrel. You would have a good result also with 5 milligrams. And this PRU is now 135. Last bullet point. Both the patient and the cardiologist feel a lot better. And I'd like to conclude with this slide to give some acknowledgement also to genetic testing. We spoke about 2C19 being associated with less generation of clopidogrel active metabolite, less platelet inhibition, and a greater risk of stent thrombosis. I don't want you to give me an answer, but keep this question in mind. If you were to be a poor metabolizer to clopidogrel, had a heart attack, and a stent to your LAD, would you want to go home on clopidogrel 75 milligram based on these results? Thank you for your attention.
Thank you, Dominick.
Thank you. Mine is a real rebuttal. I use some of Dominick's slides to comment them. So this is his basic slide. I mean, all the advantages of monitoring. The point is it true that this is the real situation today? We already know that Verify Now is one of the potential tests, but it's not the only one. We do not know whether it is the best one, as you remember. Risk stratification, well, now we have a new cutoff, 240 by Mangiacapra, which I didn't know before looking at Dominick's slide, which adds to the confusion. Is 240, 208, 235, 230? I don't know. What about clinical guidance, improved outcome, and better patient care and cost saving? I already mentioned this, that we are not ready yet. Maybe in the future we can say that this is true, but not, today we do not know. But there is something I absolutely agree with Dominick, that we need individualized treatment, antiplatelet treatment, to improve our performance. We have to increase the number needed to harm and decrease the number needed to treat. They are not satisfactory. But what do I mean personally by individualized treatment? We have to identify a priori what patients should be treated with antiplatelet agent and with what agent and so on. So let's go to the two guys that Dominick knows well. Javier and Paco, actually they do not look like Spanish to me at all. I think they look like Italo-American mafia men in the 1930s. So that's why I call them Luciano and Lucky. You might remember this guy, Lucky Luciano, who was a mafia man. So if Lucky and Luciano, which is the right pronunciation, is not Luciano, it's Luciano in Italian, undergo acute coronary syndrome, they may have two clinical endpoints. Lucky, no further events, and this is what happens to the majority of patients, as you know. So he doesn't need any antiplatelet treatment. Luciano has recurrences, and to prevent them, we have to give him aspirin. Within the same group, there is other Luciano and other Luckys. For Luckys, aspirin is enough. For Luciano, aspirin is not enough. They will have another event. So we have to give Luciano another treatment with P2Y12 antagonist. And with this DIN score, there are other Lucianos and other Luckys. Luckys are okay with the double antiplatelet treatment. Luciano is not. What to do with Luciano in this case, we do not know. Change P2Y12 inhibitor, add another antiplatelet agent, or maybe not give him or her, Luciana, antiplatelet treatment at all, because the thrombus that forms in his or her coronary arteries is not platelet dependent, maybe. So once we will be able to identify a priori all these Lackeys and Lucianos at different levels, we will improve substantially our performance in terms of increasing the number needed to harm and decreases substantially the number needed to treat. This is, of course, a long way, much longer than the Camino to Santiago de Compostela, which crosses here, if I remember well. And I'm sure that once we get the first result, I will be retired, but I hope I will still be alive. So I only also have this slide for those who are called Luciano here, just. Okay, thank you.
Thank you very much. Thank you very much, both of you. You are excellent speakers. And now the time for discussion is open. I hope that you enjoy this excellent round table and controversy. And please, you can ask any question now.
Thank you. I have a question for Professor Cattaneo. Thank you very much. And, would you be maybe softer in your denying the potential benefits of tailoring therapy in patients with monotherapy with clopidogrel, for example, due to intolerance to aspirin or due to an indication for a previous TIA or so on? In these cases, maybe the consequences of being responder or non-responder could be worse than in a patient already on aspirin.
Yes, of course. I'm not. My religion is not against monitoring. The question I'm trying to make here is that we will have to do it to monitor, to tailor treatment based on laboratory tests once we know how to do it, and once we know that doing it is better than not doing it. So today my answer is no, but I hope that in the near future there will be studies that will prove that you are right, and I will say you are right, and I will suggest doing it. I will not do it because I'm not a cardiologist, for the lucky of the patients, but that's the only point I'm trying to make. We have to do it once we know that it's good and we know how to do it.
May I add a comment? I just wanted to add, your comment's very interesting because of the concept of patient on monotherapy, especially right now that we're going to have a generic clopidogrel, and one can say, should we be stopping the aspirin and continue with clopidogrel? We're actually doing a study right now because we do believe that maybe we can individualize treatment and maybe choose clopidogrel over aspirin according to the patient phenotype. We're doing a series of functional assays, but we're not making our decision based on our result of the aspirin. We just think we're just looking to see if clopidogrel can give a more comprehensive inhibition of thrombotic profiles. You've probably heard a lot about the smoking paradox, and actually a lot of our patients who are on monotherapy, we're just switching to clopidogrel because they have a higher event rates, but they're being more protected by clopidogrel than with aspirin.
Thank you for the debate. This is a question also for both. You have both all touched the point of the right moment to measure the platelet reactivity, and the question is if there is any data, reliable data, on the variability is different from different time points, and also if we need during all the course of the disease the same amount of anti-aggregation. I mean, it's the same for the first 30 days and also for a year on, or is there any data on that?
So the answer to the correct time point is a mystery. Okay, so we've learned from one of the Italian trials, actually, that the time point with better prediction is actually at 30 days and not immediately after the procedure. And to a certain extent, it makes sense because immediately after the PCI, you have a lot of variables going on. So it's normal that that can be influenced. The problem, and this is something that I highlight in my JAM editorial, is then, well, if you can't do it immediately after PCI, and the highest risk of events in the first 30 days, well, then what do we do? And so maybe we need to change the cutoff point. So the answer is yes, we know that maybe later is better when platelet function is stabilized, but then the trade-off is how are you going to predict events when they happen in the first 30 days. In regards to changing treatment, this is another important concept. Maybe we need to modify doses over time. The further away from the acute event, you may want to modify doses. There's a trial going on in Italy, and I believe, Marco, you're involved with this as well, with Tullio Palmerini, in over 1,000 patients with acute coronary syndromes, doing serial testing and looking at outcomes at 1 year to address the specific question. So once we have the data, then maybe we can do a tailored trial.
Yes, I wanted to mention also this trial that Tullio Palmerini and myself organized a couple of years ago, and then we involved also Dominick. I also wanted to mention the 30-day time point that Campo and co-workers set up, identified as the best predictor. And I absolutely agree with Dominick. I mean, the vast majority of events occurs within the first 30 days. So what is the usefulness of having a test which predicts what will happen in the future when most of what we want to avoid has already happened? That's why I suggested, why don't we use the good drug at least in the first 30 days and then maybe change them?
Yes, thank you for this nice and relaxed debate. I think it's very interesting. And this is a question for Dominick. In your last case, you used the platelet testing and you end up giving a potent P2Y12 inhibitor to a patient with a recent bleed, GI bleed. So at the end, you use what you could have decided with clinical risk stratification. This is a high-risk patient, and in high-risk patients, this is proven that they're most benefit for the most aggressive antiplatelet therapy. The problem with the strategy used is that at the end, you have to balance the benefit. There's no question that you can kill the patients as much as you wish. The problem is the other side of the coin, which is the bleeding. So you said you were very comfortable what you decided, but we don't know if he bled or not later on, which is the other side, the cost of your decision. You could have done that just with clinical decision making. So my question is, what's the benefit on clinical decision making, on clinical risk stratification? And the second thing is, how do you use platelet testing to stratify bleeding risk, which is the other side for your decision making?
Okay. So your point is very well taken, and I want to reemphasize that I'm not a proponent of doing routine platelet function testing, and actually I'm one of the strongest advocates. Use your clinical judgment, and let's base our decision based on large-scale clinical trials. So having said this, to further address your question, the answer is no, there isn't a single study. Actually, there is a study, which is the popular study, which has shown that adding platelet function testing does not allow you to further risk stratify. So the answer is correct. What's happening a lot, however, in clinical practice, at least in my center, we're getting more and more patients who are informed. They get on the internet, they read, and they come and they say, you know what? At the private practice in the other part of the city, they're doing platelet function testing. And so, but here at University of Florida, aren't you doing this? And the truth is, we do not, unless there's some important patient coming, and every single patient that we do a test on needs to sign an informed consent. And so basically all our clinical judgments are really driven clinically. This is a specific patient, very high-risk patient. There are some specific requests to do the test. I'm not allowed actually to do the test if I don't get a consent from the patient. But we made an exception. We made an exception here. But your point is very well taken. Use your clinical judgment.
And what is your opinion in this question?
Well, I absolutely agree. Clinical judgment is the best strategy in any field of medicine, I believe. So.
Thank you very much for the speakers. It's a very interesting controversy, and I would like to thank the attending person.